Welcome, ladies and gentlemen. My name is Dr. Sangwoo Ham. Before I begin, I would like to congratulate Vice Institute for marking its 20th anniversary this year. Under the leadership of senior faculties Drs. Mark Kwon, Bernard Jin, and Albert Louis, many of us have witnessed what the excellence and advancement in implant education that Vice Institute has offered. And I do not doubt that Vice Institute will continue to do so. As a matter of fact, I am one of those who have significantly benefited from what Vice Institute has offered, and I invite many of you to join and grow together with me. I am honored to be invited to be a part of this 20th anniversary online live conference and share my experiences with many of you joining me today. I'm sure many of us have experience with some sort of overdentures, and some of us may have already have experience with implant overdentures. We know that many patients who are completely edentulous benefit significantly from implant overdentures, especially in the mandible. We also know that traditional workflow is quite cumbersome. Let's review the traditional workflow. First, we remove all the teeth and graft and give patient an immediate denture. Then, after 4 months to 6 months of healing, we place implants and we wait again. Once that's healed, we expose, and then we can make the implant overdenture. After almost to a year since the start of the treatment. Imagine the number of relines and a follow-up points you have to do to make this treatment successful. And how satisfied are we with the immediate denture at the first try? How about after multiple relines? And how satisfied are patients with those dentures? Or is it just me who have difficulties with this immediate dentures? Let's just imagine, what if we can immediately load these dentures to the implants? What if we could do so in a consistent and predictable and successful manner? Wouldn't that make our experiences much better? Wouldn't our patients benefit significantly and have a positive experience through this treatment? And most importantly, wouldn't our patient benefit in their lives with these kind of treatment modalities? Well, that leads to today's presentation, an overview of case selection and workflow of immediate loading of implant overdentures. Just to share a story of mine, implantology is one of the reasons why I love dentistry. Through dentistry and through implantology, we as healthcare professionals have the capability and the knowledge to impact patients' quality of life. Therefore, I always strive to do the best for my patient, and that is why I devoted my clinical practice to predominantly implant surgery and oral surgery, with the great team that I have that I work with in my clinical practice. I also feel very fortunate to be able to connect with talented clinicians through Vice Institute and other educational programs, because these opportunities help me become a better clinician and do better treatment for my patients. When we discuss immediate loading treatment for terminal dentitions, we often refer to all-on-X treatment in general. And yes, with currently available digital technology like R2Gate, we're capable of providing state-of-the-art solution to our patients, like Dr. Mark Kwon's FP1 zero bone reduction full arch therapy concept. However, there are still barriers for these patients from receiving such treatment. And those include financial factors and patients' capability of maintaining good oral hygiene. We all know that fixed prosthesis solution is not for every patient, and for those specific patients, sometimes removable prosthesis is a better long-term solution. Then the question is, can we predictably immediately load the overdentures to our removable prosthesis? When I first learned implantology and the concept of cross-arch stabilization for full arch therapy, fixed splinting of multiple implants was one of the key criteria for successful outcome. For example, this review article from Journal of Prosthetics suggests that cross-arch stabilization by splinting full arch minimizes micromotions and stimulates bone growth. In other words, the removable prosthesis and immediate implant did not go well hand to hand. But that's now the past. What does the current literature say about this concept? As many of you may guess, the current literatures do suggest the high predictability of immediate implant therapy for implant overdentures and the mandible. In fact, my colleagues and I from Bison Institute have performed hundreds of immediate loading of implant overdentures for over a decade, and we now have a predictable protocol that we follow that gives high success rate. The general protocol often do suggest a bone reduction to achieve high primary stability by circumferentially surrounding the implant fixture with basal bone. But that's not the whole picture, is it? For a clinician to successfully complete a treatment on a consistent basis, one must establish proper case selection protocol and employ an efficient clinical workflow. And today, I am here to share some of my insights and clinical decisions that I make for my clinical cases of immediate loading of implant overdentures to make it consistently successful. So, who is a good candidate for implant overdentures? Theoretically, anyone who is interested in this kind of treatment modality. But in my clinical practice, patients who often end up with immediate implant overdentures are those who seek full arch treatment but have short or long-term risk factors, including compromised oral hygiene or limited finance, as I alluded earlier. Compared to fixed prosthesis, removable implant prosthesis allow patients to have, with compromised oral hygiene, like for example, compromised dexterity, to have an easier daily maintenance protocol for their implants. And for those patients who have limited finance but are hoping to have it convert into fixed prosthesis in the future, implant overdenture is a great interim treatment for improved function and comfort with less financial burden. And of course, as a definitive treatment, this is a great treatment modality too. Now, without further ado, let's talk about the protocol that I find predictable in my clinical practice. From my perspective, there are few goals that I try to achieve in immediate implant overdentures. And those include 4 implants, not 2, but 4 implants with minimum insertion torque of 40 Newton centimeters with ISQ value over 70. And when I say ISQ value, that's insertion ISQ value at the time of the surgery. Also, sufficient existing or planned vestibular depth with minimum keratinized and attached gingiva of 2 millimeters around the implant fixture. Last but not least, the prosthetic should have sufficient prosthetic space to allow the teeth, the gingiva, and locator housing. And that should be pre-planned before even you touch the patient. Now, let me share a case that shows the overview and how I execute these kind of cases and share the techniques that I utilize to make it work. Here's a patient, 62-year-old male, heavy smoker and heavy drinker, otherwise healthy. As the panoramic radiograph suggests, the patient presented with generalized periodontitis and generalized tooth mobility. He came to me for a consultation regarding full arch solution for his upper and lower arch. However, the patient's financial status did not allow for fixed solutions yet. So we decided to proceed with a removable prosthesis for now, building up to the fixed solution in the future. So here is the Artigate planning of the case. You may recognize the planning that follows FP2 design of the lower arch. I like to plan my implant position for removable prosthesis following FP2 design because it allows me to have the flexibility to convert into a fixed arch solution in the future without any compromise and without using multiple MUA, multi-unit abutments. Therefore, so I can use a direct into the fixture prosthesis for full arch solution instead of using an MUA, which can contribute to plaque accumulation in the future. And this is where the digital dentistry shines, because by utilizing digital dentistry, I can angulate and position the implant so that it satisfies both removable and fixed solution in the future without any compromise. In other words, we can precisely and accurately position implant fixtures so to adequately support future prosthetics according to the occlusal scheme that you have designed without any compromise. And also with the given angular correction that ZES locator can provide, which is up to 40 degrees if you want to, the angular deviation that is inevitable with the implant fixture positioning becomes insignificant. And in this case, I have not planned to do any bone reduction because the vertical bone loss from the periodontal disease fortunately turned out in my favor. Therefore, I decided to perform guided bone regeneration to increase the horizontal width with fixture and placement for implant overdenture and for future fixed prosthetics. So here's the immediate post-op and the radiograph of the case. 4 fixture has been placed with minimum insertion torque of 40 centimeters, but at the same time, I try to take an ISQ value, but in this case, because the blue diamond system that I utilized in this case was relatively new, the ISQ pegs were not available. So in this case, I was not able to take ISQ, but if I did, I probably got 70 and over. And you also may notice that the abutment locators are relatively longer than usual, and these are 4 and 3 millimeter height locator abutments. I generally like to apply zero bone loss concept for all my cases, and therefore, the fixtures that here I have placed approximately 4.5 millimeter subgingival, which necessitates the use of longer abutments. And typically, it ends up being a 4 millimeter locator abutment. Of course, all extraction sites were grafted, and guided bone regeneration was completed around the implant fixtures where there's been significant bone loss. ZES locators were utilized and picked up with his new immediate lower denture, and the denture was given to the patient to be loaded the same day. Of course, PRF, plain rich fibrate, was utilized as a part of bone grafting. Now you may wonder, what is the benefit of immediately loading locator overdentures? Immediate loading of locator overdenture had many advantages. First, soft tissue healing is unbelievable. You can see the excellent healing at 2-week mark of another case of mine and 1 month post-op as well. The excellent soft tissue is incomparable with any other treatment, maybe other than the fixed solution. And also the immediate comfort and the functionality the patient achieves from this immediate loading is a significant improvement. And of course, the hygiene is also simple. After 2 weeks, patient can take it out and clean it every day, which makes this treatment modality very favorable to those especially with compromised oral hygiene, because they can clean the implants very, very well. And of course, that retention is very satisfactory over conventional immediate denture. So what is the steps after fixture placement in order to get these kind of results? So after insertion of the implants, we should be doing bone reduction as necessary. We need to pick up the implant fixtures with the locator housing accurately, meaning you need to make sure that the housing is in and picked up at the same time, and there's a specific protocol so that we can pick it up at the same time with precision. And of course, the material that we use to pick up that locator housing could be any material of your choice, but personally, I use a product called Quick Up because it works quickly and it's hard enough for me to pick up and also easy to adjust. And of course, after the denture is delivered and polished, I give it to the patient and tell them not to remove for 2 weeks. Not 1, not 10 days, but 2 weeks, because we find that 2 weeks is a key magic time for the soft tissue to heal very, very well. So here is the 1 month follow-up and the 2 month follow-up of the case that we just showed you. You can see the overall good soft tissue healing around the fixtures. And 2 week mark, there's 2 things that I recommend or that I tend to do for each cases. Not every single time, but in many cases. First, I look at the sleeves within the housing. If the black housing is worn out, I change to a higher retention sleeve so that it'll be stronger and better retention. And sometimes I have to realign the case if the bone remodeling is significant. And the case that we did today, all I had to do was a little bit of realigning, but otherwise it was quite looking good, as you can see in the photo there. Now here is the 4 month follow-up. You can see the panoramic radiograph that there is a good maintenance of the bone around the implant fixtures. I don't often do this, but I did remove the locator housings and locator abutments to measure the ISQ. All of them were above 75. And of course, after 4 months, I always do fabricate new final dentures, with or without reinforcements, depending on the occlusion. If the lower denture is against a natural dentition or very strong bruxism, I often recommend having either metal or fiber reinforcement within the denture for increased strength. But in cases like this, where it's just against a regular denture, that is not necessary. Now here's the 1-year follow-up of photograph and a radiograph. You can still observe the adequate soft tissue healing around the implant fixture and the bone maintenance around the fixture on the panoramic radiograph. And also, the prosthetic is still functioning very well and sturdy. And patient is now ready and is planned to be converted to the fixed prosthesis in the future when his financials is ready, just like how Dr. Kwon does FP1 design for his full arch treatment. Now you may wonder, why do I do these sometimes risky treatment, or why I do these immediate loading that may seem risky? One famous person said that people don't buy what you do, but they buy why you do it. I do implants because I know how impactful I can be to my patients through implants and giving them a second chance with their teeth. And patients find that valuable to them. And that's why they come to me. And to me, respecting that trust that the patient has in me is important by giving them everything I got, doing everything I can, and utilizing every tool I have in order to give them a result that they deserve, or if not better. And that is why I do these treatments and try to provide something better for patient every day. Now, you may say immediate loading of locator denture may have been around for over a decade. Is there anything better that you think that's coming in the future? And yes, just a peek into our future, this whole process can be completely digitized and executed digitally with high precision and predictability. And I am looking forward to share that with you in the near future as well. I hope you enjoyed my presentation today. I hope you learned something today. I try to give you a good overview of immediate locator denture and what I do in my clinical practice. And I hope you'll be joining me when I do and share my digital workflow of immediate locator denture in the near future. Thank you very much and have a great day.